We go on to our next speaker, Dr. Supriya Sriganesh, who's the Executive Director of the Netradama Group of Hospitals at Bangalore, a young dynamic surgeon and who's really taking a hospital miles forward. And she's going to talk on managing retained lenticules after smile. So on to you, Supriya.
Thank you so much, ma'am, for having me. It's been a great 1 hour of learning. We've seen so much so far, and it's been very interesting. And I'll be today showing a few cases of management of retained lenticules after smile. I hope my slides are visible, ma'am.
Yes, yes.
Okay. So retained lenticules are a unique complication of lenticule extraction procedures, and it can be caused because of black spots, thin lenticules, and improper dissection techniques. And we run the risk of irregular astigmatism. So I just want to play this one video where the lenticuloschisis technique is being done. As you can see here, this is a slightly stronger, denser cornea, and the pattern of energy has not come out perfectly. It's a sticky lenticule, and the forceps is being used to do the lenticuloschisis. So these are, as ma'am, you pointed out earlier, not all cases are suitable to do lenticuloschisis, and this is one such instance where because of the difficult dissection, there's a lenticule tear right there. So you can see that at the periphery, there's a small tag of tissue. Now, intraoperatively, when we notice these small tags of tissues in the periphery, it's imperative to go back in the same sitting and try to remove that piece of tissue with meticulous dissection. Ideally, what needs to be done is a rescue instrument like the Chansui dissector can be used to dissect the superficial and deeper plane so that the edge is dissected. Here, the small piece of tissue was peeled off and removed, and you can unfold the lenticule, and this fits like a jigsaw puzzle so that you have the entire lenticule out. And luckily in this case, we were able to note the lenticule intraoperatively itself and didn't allow it to go postoperatively. Now, there are three different situations. If there are small tissue tags in the periphery and the uncorrected vision is not affected, you can leave it alone without any intervention. If there is a mild corneal irregularity, the uncorrected vision is affected, but best corrected vision is improving to 6/6, you can consider a topo-guided PRK. If the whole lenticule or large fragments of the lenticule are retained, especially near the visual axis, a surgical exploration is required, and there are two approaches to this. The original incision can be used to explore the pocket, or you can convert the cap into a flap using the circle software. Now, I'm just presenting three different cases from Dr. Ganesh's archives, showcasing these techniques. This is a case of a 24-year-old male who underwent primary smile, and the vision was not improving beyond 20/40, and after the resurgery, it improved to 20/20. So you can see on the left side, this is the preoperative topography. You can see a significant steepening, inferior steepening of the cornea, and on ASOCT, you can see there's a large piece of retained lenticule there. This was the video of the resurgery. So the original smile incision is being used to explore the pocket, and this is a rescue instrument. This is the Chansui dissector. It's a sharper dissector. So this is really required to go beneath and above the lenticule and dissect the planes. A meticulous dissection of the planes and the side cut is required to completely free the lenticule before removing it. So here we thought that it was, here we actually thought that it was a part of the lenticule or a crescent-shaped lenticule which was there. But upon dissection, you can see here that after removing it with a forceps and unfurling the lenticule, that it's actually the entire lenticule which was retained in the pocket. So the primary surgeon has pushed the lenticule down, it's tacoed upon itself and gone inside the pocket, and the lenticule has finally been lost. So this is the entire lenticule being removed, and after this, the patient was 20/20 post-operatively at 15 days. This is a second case where we've been speaking about black patches and not black spots. So there's a difference between spot and a patch. You can see here in the primary surgical video that there's a black patch, which is there superiorly. And since it was not in the visual axis, the primary surgeon went ahead with the dissection. You can see that it's a very difficult dissection, especially for the deeper plane. And although it was a difficult dissection, it was gone ahead with. and the entire lenticule was removed in toto. So you feel like the whole lenticule has come out and it'll settle down. But in these cases of black patches, sometimes you can dissect within the lenticule and a layer of the lenticule can be retained. So this was the case. You see there's a significant steepening centrally here. And on ASOCT, although there is no significant retained lenticule and the epithelial maps are normal, on the retroilluminated photograph, you can see the margin of a retained lenticule, which is significantly seen on retroillumination. So in this kind of case is where you need to convert the cap into a flap with Circle software and explore. Here you can see the bump which was there centrally, which is just easily being picked off using a Siebel's flap lifter itself. And after removing the lenticule, you can see that because of the black spots, the interface is quite rough. So a 20 micron PTK was done to smoothen the interface, and then a BCL was placed. And after the removal of this retained lenticule and the complete smoothing procedure with the PTK, the patient did much better. So you can see here the PTK being done, after which the flap is just reposited. So you can see post-operatively, this was the change in the topography, and the retroilluminated photograph is clear and interface is clear, 20/20 parts on day 1. This is another case where a completely false plane was dissected. The 31-year-old female presented with a history of complicated smile 2 days back, referred from another center. And the uncorrected vision was 20/60, but the best corrected vision was improving to 20/20 parts. The entire lenticule was actually retained inside. So this was the video of the primary surgery. You see, it's a good pattern, but the deeper plane has been dissected first. So you see the surgeon goes in the center and enters the deeper plane, has not realized it, and does the complete dissection. And here, as the cornea has a lamellar structure, it's very easy to enter a deeper plane. You see a very traumatic dissection is being done. A whole new plane is being dissected there. But since there's no side cut between the deep plane and the newly dissected plane, using the forceps, the surgeon is not able to remove that lenticule at all. So it was referred in this condition. On the ASOCT, you can see a much deeper plane at around 298 microns. And you see a hypodense lenticule there. So this is the resurgery. The cap was converted into a flap. And using a fiber optic illuminator, the edges of the lenticule were delineated. And most of the lenticule edge is able to be dissected by the short end of the dissector quite easily. Only the nasal side, the long end is used to complete the dissection properly. Here is very important to make sure there's no pieces of retained lenticule. The whole lenticule is brought out and the flap is reposited. You see here, post-op 1 month, the patient is 20/20 after the entire lenticule is removed. This is the ASOCT. Although there is a deeper plane there, it's one plane which has been dissected, not multiple planes, so it's not caused a significant refractive change. So proper technique of docking, energy optimization, and meticulous surgical technique are the most important things in minimizing complications and good visual outcomes in SMILE or lenticule surgery.
Thank you. That was again another wonderful presentation, Supriya. Dr. Sonu Goel, are you there?
Yeah, excellent presentation, Supriya. And I think you and Shri, what series of cases that you presented. One point I just wanted to add that whenever you are in such a situation, I think if you do a full mydriasis and then you dissect, I think that retroillumination is a very great aid in capturing these retained lenticules. So we have tried a number of our own series, and I think it really works well. You need not to actually stain the retained lenticule. Under the retroillumination, you can actually outline the entire retained lenticule. And it's basically the 6 o'clock position where you tend to, in very thin thickness, thin lenticules, that the chances of retained lenticule are there. So actually, it's the 6 o'clock which you showed in 2 of your cases. Yeah. I think very nicely pointed out.
Thank you so much, sir. I think
yes. Go ahead. Sorry.
Yes, sir, please. I was just going to say that the retroillumination really helps. And also in very thin lenticules, what we do is we increase the minimum thickness, the peripheral thickness of the lenticule to about 30 microns, so that, the chances of retaining peripheral tags are lesser, especially in low myopes.
Yes. Shreyas, you wanted to add something?
Yeah, no, just quickly, I mean, very nice set of videos, Dr. Supriya, as always. Just adding to what Sonu sir was saying, we found this very useful and dilated retroillumination, and using your cataract microscope rather than your regular refractive microscopes. Obviously, the coaxial illumination is better in our cataract microscopes. So shift the patient to a cataract theater and do it. And also using a little bit of IVTA gives that contrast in just injecting into the interface, because these granules get deposited at the edge of the lenticule. You can actually make out the retained part of the lenticule, the edges of the retained lenticule. So that also helps. And regarding that wrong plane dissection, while the one which you showed was tremendous, where he has somehow the surgeon has managed to go through to the entire interface. Very often, what I've seen when a couple of times when I've had to remove such lenticules is where a small deeper plane has been tried. This is essentially because the surgeon believes that they have done the anterior and try to keep going posterior, do a little bit of dissection and then leave it. But most of the time, if we just use our regular techniques of how we reach our anterior plane, and what you would do if you were the primary surgeon, and thinking that nothing was done and just approaching it, we've been able to remove those lenticules. Converting to a flex or using circle may or may not be necessary, although you did it very elegantly. But just approaching it as if no surgery has been done to the anterior plane oftentimes works out very well.
Absolutely. When you have the primary surgical video, or if you have done the surgery yourself, when you know exactly what's happened, because this is a case that was referred and we had no idea what the previous surgeon had actually done. So, which is why the open exploration was done. But absolutely using that technique of coming into the superficial plane first, because if you cannot find the deeper plane, usually you're in it. So trying to find the superficial plane instead of digging further in and trying to find a deeper plane usually helps. Going into that 1 mm gap between the cap and lenticule planes and just lifting up slightly and going to the superficial plane is a great rescue technique to find the plane and continue just with the original smile incision.
Absolutely. I mean, in fact, while teaching new surgeons for either clear or smile, in fact, I've started using that as the go-to technique for all cases, rather than the straightforward dissection that we normally do, going into the 1 mm gap and lifting it up and going into the anterior. More often than not, most new surgeons find that very easy to do, and they don't go into the same learning curve that we have in identifying anterior and posterior.
Exactly, agreed.
How late has anybody removed the lenticule?
Ma'am, it was 2 days post-op.
No, how late? How late? Beyond the like a patient has come from elsewhere and you find as a smile.
Yes, it was 2 days after the primary surgery, ma'am. It was referred to as immediate.
Have you done? Would you do it even 1 year later or 2 years later? Is what I'm asking.
1 year. Usually, such cases probably within 3 months it happens, ma'am, because the patient has come to you for refractive surgery. They don't want to wait for such a long period of time, and usually the surgeons, the maximum they wait for everything, the edema and inflammation, everything to settle down is about 3 months, after which it's taken up for secondary surgery.
I think we have done about a month later after the primary surgery. And apart from the several points that were made, I think looking at the primary video of the primary surgery is really helpful to identify where exactly things went wrong. And secondly, also apart from the ASOCT, I find that topography also gives us an excellent indication as to where to expect the retained lenticular fragment to be there. Because you find that the corneal thickness is quite significantly higher there. The curvature change is there, so you can go in expecting the fragment there. Of course, using retroillumination and transtone acetate diluted also helps you to get it out more. But a beautiful set of videos. Nice.
Thank you,
Thanks,
sir.
Supriya.